Hello, my name is Preston, and this is my capstone project on high-flow nasal cannula use in pediatric respiratory distress. This project will give an overview of the high-flow nasal cannula system, as well as go over some physiology and some clinical indications and efficacy. So, overview. High-flow nasal cannula is starting to see an increased use primarily in our pediatric populations. It's because it is a excellent treatment method that is going to help mitigate the need for invasive airway management, such as intubation. The PICO question used for this was in pediatric patients experiencing respiratory distress. How does the use of humidified high-flow nasal cannula oxygen administration compared to other forms of oxygen delivery, including no intervention, affect the clinical presentation of patients during hospitalization? The literature review was done through Medline text. The limitations and filters placed were within 5 years, full text articles written in English, and then the keywords used in various combinations were high-flow nasal cannula, pediatric respiratory distress, pediatric high-flow, and oxygen administration in pediatrics. In 2015, there were 30 million ED visits for patients under the age of 18. 40% of these patients were actually under the age of 5. So it's important to note because patients of this age tend to suffer from mostly respiratory issues. And a lot of this it boils down to the fact that they're more prone to these respiratory emergencies due to their anatomy. These patients, compared to your adult population, which tend to have a more tubular airway, these patients are actually going to have a more conical or funnel-shaped airway. Their larger occiput, which is it's going to be the back of the head, is going to cause some issues as well. They suffer from what we call, in the emergency setting, a big head, little body syndrome. So that disproportionately large back of the head is actually going to cause, when they're laid flat, it's going to cause neck flexion, which is going to occlude the airway. Also, despite what some readings say, these patients are actually now defined as preferential nose breathers as opposed to obligate nose breathers. They are also, especially your neonates, are at risk for energy depletion, especially when they go into these respiratory distress or respiratory emergencies. So this is a nice little mnemonic from Rebel EM, which if you are involved in emergency medicine in any way, Rebel EM is I highly recommend it. It is an excellent resource. So it talks about high flow provides heated and humidified gas, can better meet elevated peak inspiratory flow demands, increases the functional residual capacity through PEEP. It is lighter, therefore more easily tolerable than CPAP or BiPAP. Can minimize oxygen dilution by meeting flow demands, and it provides high flow rates, which lead to the washout of dead space, which we'll go over here in just a moment. So how does it work? So it provides heated and humidified oxygen through a nasal cannula. It heats it to about 34 to 37 degrees Celsius, providing up to 100% humidity. It also is able to deliver up to 100% FiO2, and is able to deliver that at rates of up to 60 liters per minute. There are two main companies producing these, Vapotherm and Fisher-Paykel. Vapotherm delivers up to 50 liters per minute, while Fisher-Paykel delivers up to 60. Fisher-Paykel also has two units, the OptiFlow and the Airvo 2, which currently in my unit, as well as our transport teams, I'm seeing a lot of the Airvo 2 as opposed to OptiFlow or the Vapotherm. And that boils down to ease of use. So we'll see why this looks a lot more complicated than this does. This is also a lot more compact, easy to use, especially for our transport teams. So some physiology key terms: tidal volume, which is the volume of air that enters and exits the lungs during respiration. Positive pressure, basically the pressure inside is greater than the pressure that is outside. Positive end expiratory pressure, or PEEP, which is positive pressure remaining at the end of exhalation. And then dead space, which is the volume of ventilated air that does not actually participate in gas exchange. So some physiology of inspiration and exhalation. Ventilation is actually the volume of air that is moved in and out of the airways. And then everybody's favorite thing from chemistry and physics is gas laws. And one of the most important ones involved in ventilation is going to be Boyle's. So Boyle's gas law states that the pressure of a gas is inversely proportionate to that of the volume of the container. So in simple terms, as the volume of the container goes down, the pressure of the gas goes up. So how does this apply? I mean, what does this even mean? So differences between atmospheric pressure, or the pressure of the gas that we're breathing in, versus the pressure of the gas within the intrapleural space, which is in our lungs, and the intraalveolar space, which is the alveoli. This is actually what is going to result in gas exchange. And then applying Boyle's law to ventilation. So as the thoracic and the diaphragmatic muscles expand, it is going to allow lung volume to expand. Therefore, as the volume increases, the pressure decreases. So as the pressure decreases within our lungs, and then becomes comparatively lower than that of the atmospheric pressure, air from the atmosphere is going to move into our lungs. So once that is complete, gas exchange is taking place between the air now within the intrapleural space and the intraalveolar space. Then your muscles are going to contract, which is going to decrease the volume of the lungs and therefore increase the pressure of the lungs, the gas inside the lungs, which is going to cause you to exhale. So heat and humidification, why is it important? Especially in emergency medicine, if you have a patient come in, you put them on nasal cannula 1 to 2 liters, you're going to get them stable and transfer them to the unit, or you're going to fix their problem and send them on their way. So heat and humidification are not something that's really on your radar at that point in time. Now, for high flow, there's some reasons why it's important. So your standard oxygen delivery system's usually not heated or humidified. Non-humidified air can actually lead to airway inflammation, which if you're having a problem with your airway, it's going to further exacerbate your problem. Impaired mucociliary function. So you have these microscopic conveyor belts within your respiratory tract that help move the movement of mucus. Mucus traps particles. Then eventually it comes up from the lower airways up to the upper airways, and then it is expectorated, or you cough it out. Long story short. So if we impair this, then we lead to further respiratory issues. And then you can also have the risk for increased caloric expenditure in relation to gas exchange and in relation to ventilation. Cool air leads to the drying out of the mucous membranes within the airway, which again just causes more problems. So adding heat and humidification to this process help prevent the airways from drying out and decreasing the expenditure of energy, and allows for us to get the stuff out that doesn't belong within our respiratory tract. Washout. This is something that some of you may not have previously known about or experienced and learned about. So what we have is we have something called a pharyngeal dead space, and that is where 1/3 of the expired tidal volume is actually rebreathed. So if we're rebreathing, we're actually taking in more CO2. There will be some oxygen in there, the oxygen that is not utilized within that respiration. However, it's mostly going to be CO2. So respiratory failure can actually lead to an increased dead space. That's because we're not breathing as effectively. What high flow does, high flow forces a higher concentration as well as a higher flow rate of oxygen into our airways, therefore flushing out that CO2, meaning that when we breathe in, we're breathing a higher concentration of oxygen which increases the available amount of oxygen for gas exchange. This is just a example of the high flow nasal cannula again. This is actually the Airvo 2. So clinical indications and guidelines. So I was really surprised to see that studies in this area are actually pretty lacking. Until I was doing the research, I learned that this method is relatively new, comparatively speaking to other methods. So current studies have shown that high flow is effective. However, in some patients, primarily your neonates and infants, the other non-invasive measures like helmet CPAP may be more beneficial. This appears to be most beneficial to patients experiencing acute bronchiolitis, so your RSV kids, acute respiratory distress, and your asthmatics who don't respond well to bronchodilators. So guidelines from the Dayton's Children's Hospital: infants with respiratory distress that don't respond to conventional therapies that require greater than 1 liter per minute if they are under the age of 4 months, or greater than 1.5 liters per minute if they are over the age of 4 months. Patients who are exhibiting signs of respiratory failure should not be considered for high flow, according to Dayton's Children's Hospital. They actually want to utilize CPAP, BiPAP, or more invasive measures such as intubation. So for these patients, they will remain on a monitor, so heart rate, respiratory rate, O2 sats, and blood pressure. They'll have an RN to patient ratio of 1 to 3. NG tube feeds will be implemented, and the reason for this is, if you think about it, when that high flow of oxygen is coming in, it's just like CPAP or BiPAP. If you were to drink or eat something, that high flow of air is gonna force it into your airway, and then you're gonna aspirate, and then here we are, we've got even more problems. So for these patients, you will assess them after the first hour, and then 2 times you will assess them Q2, and then after that you'll just assess them Q4. Obviously, when we see something wrong, we report it to the doctor. So this is a little bit of information about a study done on helmet CPAP versus high flow. So the patients used for this were between the age of 1 to 24 months. The patients who were eliminated from this were children that were not hemodynamically stable, required immediate invasive interventions, or they suffered some sort of chronic conditions. So they split half and half. 20 were placed on CPAP, 20 were placed on high flow. In this study, all the patients on CPAP, there were no cases of respiratory failure, but there was 1 case of respiratory failure with high flow. So therefore, this study deemed that CPAP was more effective than high flow. However, the study does admit that statistics do show that patients who are older than 24 months tend to do better with high flow than they do with the CPAP. So some conclusions from this literature review: high flow is effective. However, in certain subpopulations, other means of non-invasive respiratory support may need to be considered. And that more studies really need to be done to completely address the efficacy of high flow, primarily in the pediatric population. However, I will note that in my personal experience that high flow has been highly effective, and that it has prevented us from having to do more invasive measures such as intubation. And then just follow the guidelines, and the guidelines that were set forth by Dayton's Children's Hospital did kind of stick close by what my institution's current guidelines are at the moment. So there will be a quiz following this, assessing the knowledge that you gain from this, as well as assessing your views on the presentation. If you have any questions, please let me know. Otherwise, have a good day and stay safe.